I'm going just to give some slides about the introduction about the deformity planning course. First of all, I would like to thank the faculty, my friends, Dr. Elizabeth Mulder and Dr. James Fernandez and Hemant Sharma for giving the lectures and supporting the scientific activities of the Egyptian Orthopedic Associations. Thank you so much for sharing us the informations. Limb reconstruction surgery continues to prove itself as a distinct subspecialty worldwide. This paper published in 2017 by Regia and other friends. They spoke of the very popular annual deformity courses, Baltimore course, Hull, and Cairo, and others. You know that the Hull conference was canceled this year for the next year. We are trying to make the 16th Cairo Deformity Correction Conference in September, 2 to 3, 4 September. We have many negotiations with the health authorities, and the airline companies, and perhaps it will happen, 2, 3, 4 September. And all the faculty are invited, of course. This was the last year. You see the crowded people in the hall. We don't know how are we going to comply with the social distancing during this epidemic. We will try. We will try not to have this crowd during the conference. We hope so. Now, is it hard to be a limb reconstruction surgeon? Is it that hard? Or is it easy to be a limb reconstruction surgeon? If you want to be a limb reconstruction surgeon, you need surgical training, of course. But the question is, surgical experts, the surgical experts, are they born or made? We think that surgical experts are made, not born. So you need training. You know this, you can teach monkey to operate. You can teach a monkey to operate, or monkey can operate. So do you think that the operations are very difficult? Especially with the limb reconstructions, the operations are not that difficult. What's the road to deformity management? What would you think? Do we need a surgeon, a genius surgeon? Do we have shortcuts? Do you need workshops, animation? Because I've seen many surgeons, you know, they have lots of animations. The operative technique is more important, or the follow-up. For us, we think that the follow-up or the outpatient clinic is number one, and you have to put it number one. If you think that you are genius, we don't think that. If you want to do deformity, you have to be simple-minded. You know, I'm a simple-minded surgeon. I'm not that clever or something like this. I'm less than average surgeon. Just, we need a simple-minded surgeon to learn deformity. Unfortunately, we don't have shortcuts. We don't. So if you think that you can have a shortcut to learn a deformity, it's almost impossible. It has to be step by step. You have to take the ladder from the bottom and step by step afterwards. The animation experience. Unfortunately, many of the teachers, I don't know, but they show you lots of animations. We don't think that it will help. And many, I don't know, not many, some of them, they claim great experience by showing animation and animation and animation. I think this is for genius teachers, not for us. We are simple-minded, but we have a huge surgical load of deformity cases. So we prefer to use the real thing, not the animation. Unfortunately, good judgment comes from experience, and experience comes from bad judgment. But you can avoid that. Now talking about the follow-up. We believe in the follow-up. If you want to learn the deformity, you have to come to my clinic, the outpatient clinic, not the operating theater. because this is the real thing for the deformity management. And this is a simple example. And in this case, bone transport, and you have about 14 centimeter lengthening of the femur with this strong man, and we have post-operative axial malalignment during length. You see the axial malalignment? Terrible malalignment. How are you going to correct this? This is about 4 months, or I think 5 months after the operation. And you see the displacement and the bend of the bent rods because of the displacement, because of the stronger muscles. In the outpatient clinic without anesthesia, we use 2 hinges and a distractor. Just 2 hinges and distractor, as you see here. This is the hinge, this is the hinge and the distractor. And we corrected the malalignment. You see, they corrected the malalignment. But still, we have translation. In the sagittal plane, we have severe translation. What are we going to do? We put temporary fixation, and we change the construct. You see how we manage the translation. 1 millimeter per day, you see here. This is the translation construct, without taking the patient to the operating theater. So you can do everything without taking the patient to the operating theater, and this is the real merit of the external fixation. The real merit of the external fixation that you can do everything later on. In most of the operations, you finish everything during the operation, but if you use the external fixation, you can change everything afterwards without taking the patient to the operating theater. You see how we corrected the residual translation. And this is the lateral, you see, by changing the construct. And this is the construct of correcting the translation. So we didn't take the patient to the operating theater again. If you want to learn deformity, do we learn something new? Do you think so? Because you have learned a lot about deformity before. The concept of a weight-bearing axis is not new. It's an old one. Also the core, we've learned it before, the apex of the deformity. So if you have this fracture lower fourth radius, this is the apex of the deformity. And you put your 2 thumbs like this. So you have an axis here. So this is the ACA. You have a core, I have an axis, and the osteotomy is the fracture. And when you move, you correct the deformity. Also, when you do wedging casts. I remember when we used the wedging casts, when we do the casts, we don't use it at the fracture site, not at the apex of the deformity, not at the fracture site. But sometimes we use at the apex of the deformity. You see here. So wedging cast is some sort of correction of the deformity. What about the deformity? What do you mean by the deformity? People think that mechanical axis deviation. So you have just a mild genovalgum or genoverum and you correct it. We don't think so. It's worse. It's worse than just mild genoverum and valgum. This is the deformity. This is the real deformity. If we talk about the deformity, this is the real deformity, you see. If you want to learn the deformities, these are the deformities, not just mechanical axis deviation. These are the deformities. Do you think it's just mechanical axis deviation? Just mechanical axis deviation. What are the consequences of the deformity? Severe deformity can be a very handicapping condition. You can have a crawling patient because of the deformity. What's the aim of the deformity correction? People think that the aim of the deformity correction is correction of the mechanical axis. You need to have a perfect mechanical axis. So if you have a genovalgum and you do osteotomy and afterwards you corrected the malalignment. Excellent, excellent. You correct the malalignment. The aim of deformity correction is changing lives. It's more, it's far more. Look to this patient coming at age 5 years old with TR syndrome, thrombocytopenia, absent radius syndrome, bedridden patient, and you see at the adolescence. You are changing lives. That's why you have to learn how to correct the deformity, not just to correct the problem. In the Middle East, this is a significant problem. Why? Because 1/3 of the population is less than the age 15. The growth rate is more than 3%. The incidence of congenital deformities is high, sometimes it's very high, because of the consanguineous marriage. Consanguineous marriage in some areas maybe reach about 50% of marriages. Conflicts. We have many victims from the conflicts. Many of them are handicapped. Theory, I know that you learn the theory. If you learn the theory from many papers, you have basics. Take care of the basics in the deformity, because many of the people who put the basics, they have very low surgical load. So they say if you have a non-functional foot, less than 3 rays, you have to do an amputation. Look to this foot. It's 1 ray foot on both sides. You see, 1 ray foot, even very deformed foot. Look how the patient walks. She's an adolescent. She's 16 years old. The way she walks with bilateral 1 ray foot, bilateral 1 ray foot. This is moving from theory to practice. You see the way she moves. And they say also one of the reasons she cannot have a normal shoe or something. So, but look here, she's running with regular sports shoe. And she has 1 ray foot on both sides. Why they said 1 ray foot you have to do an amputation? Because this is hypothetical, just hypothetical. They think if you have a 1 ray foot, you have to do an amputation. Take care of the hypothetical rules in the literature. Again, if you want to correct the deformity, you can do it with external fixation or internal fixation. We're talking about the deformity in general. We are not sticking to one way of treatment. Also, you can correct the deformity acute or gradual, or you can use both acute and gradual treatment. Like this example, if you have a genovalgum, you can do osteotomy and plating, or osteotomies and external fixation. Acute or gradual, in this case of osteogenesis imperfecta, you can do multiple osteotomies and nailing also. Also, you can use guided growth in this case. And at the end, you can do dilatation osteotomy, so gradual and acute treatment. Physiotherapy, you know, just in the, most of the people think about the, you have to have a specialized center with many people around you or something. In many cases, we work alone. And many of the people coming to us, they cannot have a specialized physiotherapist. So we teach them, as you see here. They swim, they work, they use the computer. Hospital stay, we usually have 1 day. Most of our operations are 1 day operation, or even the patient stays just for a few hours. We do nothing for the patient, just corticotomy on most of the cases. So we don't think that the patient has to stay in the hospital. We need to reduce the costs. Finally, this is our mission. That's why you have to learn the deformity correction, the deformity management. You can change the life of this patient from a crawling patient to walking patient. You can learn to change the life of this child from this point to that point. Again, you see how change the life of the patient. Can we make a difference in the life of patients? Yes, you can. Look here today. This amputated foot with severe shortening. And you see here how we had equal length on both sides, 22 centimeter lengthening. Yes, we can. Yes, we can change the life of the patients. That's why you have to start learning the deformity from this course.